Eye care for everyone is an elusive goal that many of us are aspiring, right from the World Health Organization to national governments to individual institutions. And then as we looked into this of ways of achieving it, the primary eye care approach, or what we commonly call as vision centers, seem to be offering a hope. In the past and even today, eye camps are the essential means for reaching those who have challenges in accessing or the group that is really left out from eye care. And several organizations do a large number of eye camps, including in Aravind. Last year, we did more than 3,000 outreach activities, screening over 530,000 people, resulting in close to 100,000 cataract surgeries, of which 88,000 odd were cataracts. 100,000 was all surgeries put together. While these numbers are quite impressive, a study done about 20 years ago showed that we reached only 7% of those who felt the need for eye care. That is, we went back to the villages where eye camps were held, did a house-to-house search to list people who felt that they had an eye problem, and then we matched those people with those who actually attended the eye camp, and that was a dismal 7%. And in these camps, patients with more advanced conditions are not able to be addressed for multiple reasons, including the technology that we're able to take to outreach. So in hindsight, there was a lot of clarity as to why this uptake was so low, because these eye camps tended to be a one-off. So we normally conducted once a year or at best once every quarter or so. While eye care needs are there in the community constantly, so it requires something to be available there on an ongoing basis. So this presentation is going to be talking about a particular solution that we arrived at Aravind Eye Hospital. And for any solution to be effective, it is always good to start with some key guidelines or a framework. So this is what we started with. One, we recognize that if the goal is to provide eye care to everyone, we need to have a very strong denominator or a community focus so as to ensure eye care to everyone. And this center must provide comprehensive and quality eye examination, even though this is going to be at a remote area. And then the design of this center should take into account the notion of closing the care loop. That is, starting with diagnosis to prescription to making sure that the patient is actually able to access the intervention that is been advised. Because only this approach of closing the loop really betters the patient's eye condition and resolves the issue. And equally, we also will need to manage these centers remotely because the scale wouldn't allow to put in its own managers and that cadre of people. So all that is required to run this center efficiently has to be done remotely. And all of this has to be scalable because vision centers by design would cater to a small population. So just doing one or two vision centers are not going to be adequate. It has to cover the entire population eventually. So we started off with a rule of thumb estimation of what is the denominator or eye care needs in the community. Vision centers typically have a reach of about 7 to 10 kilometers. radius, which in the context of India would be a 50,000 population. So in this 50,000 population, a very rough or a conservative estimate is that roughly 1/4 or 25% of the population would have some form of eye care need. Some of it could be addressed, some of it would not, most of it in our context would not have been addressed. If you assume a cataract surgical rate of 10,000 as the need to get rid of cataract as a cause of blindness, then this would translate to 500 surgeries to be done annually in this 50,000 population. By a similar logic, if you assume 20% of the population would benefit from wearing a pair of glasses, which let us say again very, very conservatively that they will want to change in 4 or 5 years, would translate to providing 2,000 glasses annually for a population of 50,000, since glasses break and the powers also do change. And there are conditions which require ongoing care, like glaucoma, which many studies have established affects 1% of the population, which would be roughly 500 for a population of 50,000. And similarly, in India, the estimate is roughly 3% of the population has diabetes, which would mean about 1,500 people. And then people with incurable blindness or low vision are likely to be another 100 people. So this is the eye care needs in the community of say 50,000 people, and this is what the design and the aspiration of the vision center should be to address, in case we want towards the goal of achieving universal eye health. So these are some impact figures. In Aravind, we have 79 vision centers. The first center was put up in 2004, and some of the last centers happened during the last 12 months. They cover a population of roughly 7 million, and of that, we have uniquely seen about close to 2.8 million people are registered with the vision centers. These are unique patients, not visits. Many of them would have come several times. So what this is telling us is 2.8 million out of 6.9 million people who have registered, which gives overall average coverage of about 40% of the population. And over the years, we have delivered over 600,000 glasses and performed over 150,000 cataract surgeries. If you take a specific year, that is the last year, these centers together saw close to 700,000 patients, over 100,000 glasses prescribed, and 91% of them actually bought the glasses. This is important to monitor and note. That's about 92,000 odd glasses. And of those advised cataract surgeries, about 24,000 got operated. And then there were cases which had to be referred to the base hospital, and they were close to 50,000, and of them 67% or 2/3 of them actually visited the hospital and got whatever advice for their eye condition. So we also realized that vision centers are potential enablers of tertiary care in terms of making it effective, because a lot of the work in tertiary care tends to be chronic in nature. It is around managing glaucoma, diabetic retinopathy, or corneal grafts, and so on, all of which require long or longer term follow-up. And for many of these conditions, regular follow-up and the regular intervention, change of medication is essential to ensure good outcomes and to preserve their vision. So we recognize that vision centers with a reachable population within its service area are much better placed to ensure their compliance and better outcome. So let me run through an example quickly. This is about Teni Hospital, which should be somewhat similar to many of the secondary hospitals in the country. This was established in 1985 and now has a service area population of 1.2 million. It essentially covers the district of Teni. Apart from this base hospital, it also has 7 vision centers that is completely run and staffed and run and managed by this hospital. So last year, the base hospital saw 127,000 patients, outpatient visits, while the vision centers handled another 70,000 visits. While the base hospital was able to sell about 22,000 spectacles, the vision centers sold about 10,000. Of the total cataract surgeries done of about 8,500, roughly 27% or 2,250 were done through the vision centers. And if you look at an average output of a vision center, it is close to 10,000 visits per annum, or roughly 30 patients seen per day, 1,370 spectacles dispensed, and 320 cataract surgeries. And then this is probably a critical insight, especially when it comes to scaling. With appropriate services, pricing, etc., where in the vision centers we charge 20 rupees for consultation, which is good for 3 visits, and there's also income from sale of medicines and glasses. While there's an income, it also reduces the cost of to the patient by eliminating the cost of getting these things. So when we look at the income and expenditure of running the vision center, it tends to be cost neutral. The cost is pretty much fully recovered. And then in addition, because we now don't have to do outreach for finding these patients, and then outreach does cost money, and in our context, the cost of case finding is 360 rupees per surgical case that is done, and that's completely avoided for those cases referred from the vision centers, because the patient comes on their own to the vision center and also on their own to the base hospital. And if you factor that cost saving, it is on the overall roughly around 800,000 rupees, or a little more than 100,000 rupees per vision center. Of those patients referred from the vision center, 940, with a significant proportion, close to 40%, prefer to get the surgery done in the paying side. So even if you very conservatively assume a margin of 3,500 rupees per paying surgery, this resulted in an additional net income of more than 3.3 million rupees. So you can recognize that financially it is a win, which means that as you scale and put in more vision centers, it is not going to put a financial stress on the system. So what makes all this happen? I think if we go down to the root cause, it essentially is the leadership. The leadership should really want to provide eye care to everyone in the community. That's fundamental for their good setup of a vision center. The leadership should make the primary eye care integral to their eye care delivery strategies, and not as something on the side. And then the design must be proactive in completing the loop. Referral, tracking referral, making sure medicines that are available locally, and so on. And then it also requires challenging the hospital team to kind of adopt a denominator mindset so that universal eye care can be realized. Thank you.